Gives me great pleasure to have Professor João Carlos Wink with me here today. He's an associate professor at the University of Porto and is also chair of the NIV group within the European Respiratory Society. I'm so pleased that you agreed to talk to me today and share your experiences with COVID. How are you?
Fine, thank you, Michelle. It's really a great pleasure to be here and being interviewed by you. It's really an honor.
Oh, thank you. So thinking back, really, the whole thing started nearly this time last year. And I just wondered, what were the key points that you learnt in wave one that can be helping us now?
I think that at the beginning, non-invasive respiratory support therapies were considered like they were high-risk procedures for the healthcare workers. So at the beginning, a lot of people were saying that they were considered like aerosol generating procedures. And fortunately, that has become not, it was not confirmed by real bench studies and from the experience even with the real patients. So we now know that they are more dispersing bioaerosols than really generating aerosols. And I think that work from your group at the Brompton carried out some years ago, not with COVID, but with rhinovirus, has also shown that with the proper setup of the circuit, we can also decrease even more these risks. So I think that what we've learned from the first wave was really that people that are working at the front line with these therapies are not having COVID more than the ones that are not in the front line. So we have pretty good evidence showing that the seroprevalence of SARS-CoV-2 in the healthcare workers that are on the front line, especially with NIV and carrying out these procedures, is not higher than the ones that are away from the front line. That gives us a lot of confidence in the techniques, and also the idea that early intubation was really a must. Because of this, and also because that NIV and all the therapies would not work, and it would be a risk of delaying intubation. Now we know that early intubation is not a good practice. So I think now we are pretty much confident on these techniques, and I think we can avoid intubation much more than we did at the beginning.
Yeah, I know. I felt very confident when I had, which we were very lucky, we had appropriate PPE to be going in and doing the techniques that we needed to. And it's really reassuring that we now know that the level of PPE, full PPE for areas where there is aerosols, where non-invasive support has been used, is mandatory. I think as a healthcare professional, you feel a lot more happier about going to work rather than the uncertainty about everything that we were experiencing last year, for sure. Definitely.
Yeah.
So you've touched already on the fact that early intubation isn't great and that we are now using more non-invasive procedures. Can I just get your views on that and how you would say, how you describe if there's anything else that is new this time round that we wasn't doing in the first wave?
Yeah, so as I mentioned before, there are now more literature, there are more evidence coming from France, from Spain, and also from the fantastic ICNARC database from the UK, just showing us that really the second wave was really we've seen more non-invasive therapies coming in as a frontline, and also maybe the patient itself are a little bit different at the second wave, and we have probably more data coming for us to understand, because I think that what we are seeing the second wave is that there are not so many patients requiring renal substitution, and also maybe due to the variants and due to the mutations that the virus has had. So perhaps the involvement it's different, but I think also it has to do with some of the intervention that became more standardized, like steroids or like remdesivir that is used earlier on, and that will translate into a better prognostic impact in this setting. So I think also what has emerged is that therapies are this bundle, this COVID-19 therapeutic bundle is more consistent, and people are using it more. And so I think also the presentations and the respiratory failure that we've seen in the second wave is a little bit different.
Yeah, and I think we've learned an awful lot. For example, in the first wave, we were running people very dry from the typical sort of ARDS-like picture, which was probably not helping the renal situation. And there has been a massive learning curve. And I think, as you've highlighted, steroids have made an absolute game changer within the group. And when you speak to people, if you say sort of what medication, what's out there, everyone says you've got to have steroids. If we look at non-invasive aids, we've got obviously patients are on oxygen therapy, or they're requiring high flow therapy, CPAP, and some instances Bilevel therapy. Do you have a sort of gut feeling or a sort of protocol over what treatment you would use with each patient? I'm not sure if they're still slightly eluding us in that you might look at someone and they're absolutely happily hypoxic as hell, but and you've got to wait for the blood gas. But is there a gut sort of pathway that we can follow?
Well, that's a very good question, Michelle. And I think that in the reflection that we've done with our algorithm and with the review of the literature, and also with the experience in the field, I think we will use more and more high-flow nasal cannula. I think that some of the national guidelines from the scientific societies across the globe, for instance, the UK, there was a little concern about the usage of high-flow because of the aerosolization, also because of the risks of having running out of oxygen in the hospital. But I think that now, with all the data that came out and the efficacy, I think that high-flow nasal cannula has reached a position that I think we will use it more and more early. And I think that's because of we are not delivering only oxygen. It's much more than that. So it's very different from conventional oxygen, which is really dry oxygen, and it's not very comfortable for the patients, especially the ones that are coughing, and this is drying up more and more their airways. So I think that it's not my feeling, but it's what the evidence tells us is that humidified and heated oxygen can have extra effects on this infection, and there are some evidence showing also some immunological benefits, especially in the airways of this humidification and heating. So coming to your question, what is my gut feeling is that I think we will see more and more high-flow nasal cannula earlier. why not having a high-flow nasal cannula as a first intervention before conventional oxygen? Because now we also have different high-flow nasal cannula systems. So we have the traditional, very highly performant systems like the Fisher and Paykel, the V60 Plus from Philips. We have also from Armstrong. We have also from Vapotherm. So we have the traditional, advanced, as I call it, high-flow nasal cannula system that were really running out everywhere. So there was, in the first wave, everybody was asking for these devices and they disappeared from the market very quickly. I think that in the second wave, it was possible to get them, but I think that not all the hospitals have enough numbers of these devices. So that's why I think it's very welcome that companies like Breas, companies like ResMed, companies like Vitalayer have decided to upgrade their own home ventilators and even do brand new devices to provide these high flow nasal oxygen with their devices. And with that, I mean that you can provide not so high flows, not so high FiO2s, but you can have for a first intervention, maybe you can solve a lot of the patients with this. So I believe and I expect that we will have some randomized controlled trials in the future about the impact of early high-flow nasal cannula for hypoxemic respiratory failure, not only related to COVID-19, but also related to other situations like common pneumonia. And I would expect it for the sake of comfort, for the sake of coughing and etc., that will translate into better outcomes.
I think it's been really interesting that the high flow therapies and also the oxygen demand of these patients is so high. And I don't know whether you've instigated the same thing in Portugal. I know that the hospital is opposite the oxygen centre, so your delivery isn't so much of an issue as if we look at my local hospital. It was one of the ones that was in the press for running out and having a state of emergency. And what you can see is that now hospitals are instigating oxygen reviews. Obviously, oxygen has always been a prescribed therapy and we should titrate saturations to levels that we're prescribing. But I think unless we were overtly aware that someone was a CO2 retainer, it was something that you didn't really do as you should. And so I'm wondering whether it's a bit like masks are the new norm. Is the new norm that you're going to have a person reviewing the oxygen prescription for everyone and looking at the oxygen levels in order for centres that aren't so lucky to make sure you don't run out? I don't know what your thoughts are on that.
Yeah, that's another brilliant point. Yeah, I definitely agree that this titration of oxygen should be more rationalized, and I think that we should not think of oxygen like vitamin O. It should be given in very strict dosage, and I think that titrating according to a target is really the ideal situation. And fortunately, industry has came out with some biofeedback systems that allow us to do this. So I think that in the future, what we're going to see is intelligent high-flow nasal cannula systems where you can not only decide upon what is the flow that you need for that patient, and also decide the FiO2 depending on the target saturation of oxygen. So I think that there are like 2 or 3 papers already published of the usage of these biofeedback systems to titrate oxygen depending on the targets on COVID-19, with pretty nice outcomes, especially reducing the number of interventions from the nursing side, which is quite important in this, high-risk infection. And also, as you mentioned, to make sure that we don't spend so much oxygen. I think that I've seen in some papers a decrease in like 20 or 30% of the concentrations of oxygen that the hospitals spend. So I think that is probably something that we need as respiratory professionals to push this indication more and more, because as you know, oxygen is being delivered across the hospital in all the nursing staff, all the wards, and I think that audits taking care of this situation should be more often carried out, definitely.
Yeah, I mean, I can remember you talking about the biofeedback devices and where I do my clinical work at the Brompton. I can remember a couple of years ago, we've had a couple of PhD students through evaluating these devices, and one more recently, and they've always had good positive feedback, and it's almost like this is an ideal opportunity to have this developed further, but it doesn't seem to have come out as much as what perhaps it could have. And maybe next week there'll be a product on the market and I've just underestimated it, but I do think it's definitely an area of development. One area that hasn't been utilised as much as CPAP therapy and high flow therapy is bilevel treatment. And obviously there are the risks of the self-induced lung injury with it. I just wondered whether you could comment on if there is any type of patient that bilevel therapy would be better used with.
Yeah, that's a very important question as well. I think that we have seen in the real world people using after high flow nasal cannula bilevel. I would recommend against. I think there are patients that really should be starting bilevel at the beginning, and these are the patients with chronic respiratory failure, so chronic hypercapnic patients that after COVID-19 they become even more hypercapnic and acidotic, and I think that is really a good indication for starting bilevel. But for pure hypoxemic patients, I would say, because of what you mentioned about the risks of increasing transpulmonary pressure, increasing the risks of self-inflicted lung injury, we should be using bilevel with a lot of caution. And ideally, you should be monitoring tidal volumes because you should be using what I call protective NIV as well. So it's not only the protected invasive ventilation that we should use in these ARDS patients, but we should also use protected NIV. With that meaning, you should not have high tidal volume, so less than 9 milliliters per kilo. You should be targeting. The issue is that sometimes you don't have a good measurement of tidal volume with your NIV machine. So that's one concern, and I think we're going to see a lot of new devices that can help you to measure tidal volume in these patients, to make sure you're not over-ventilating these patients and making the lesions of ARDS worse. So that's why I think that bilevel should be a last resource. Of course, we know that even for hypoxemic patients, especially the ones that are having a high work of breathing, that pressure support can reduce the work of breathing, making them less breathless and reducing the respiratory rate. And so if you have these results when you're using bilevel, perhaps you're in the right direction, but you should be very careful on the risks of self-inflicted lung injury. We've seen in the literature some very interesting pro and con debates about this issue. We probably need more data coming in, because I think that the evidence is not so strong as to make this a dogma. I think that we still need a little research on that. I expect that some papers will appear in the literature. What we have is, especially from other models of ARDS, we have like 1 or 2 studies showing that the patients that were using Bilevel for ARDS and that had higher tidal volumes were deemed to fail more NIV than the others. So I think that this is a kind of an indirect evidence for this relationship, but still we need to research more.
And I know that you've sent me a slide. If I share that slide, would you like to talk us through it?
Please.
So just give me a moment. And there we go. I've put it up large. So I'll let you talk us through it, because I think it's an amazing slide and it's incredibly beneficial.
Yeah, so this is the proposed algorithm. As you can see here, the beginning. So when the patient is under 92% of saturation on air, we should start oxygen and targeting saturation of 92 to 96%. That's here when probably these biofeedback systems could be very helpful. And also, if your needs of oxygen will increase, you can go up until reservoir mass, where, as you know, can deliver up to 95% or 90% of FiO2. But I think that in this part of my slide, so step 1, which is conventional oxygen, I think probably we will see in the future that iFlow can be an intruder here in between, when the needs of oxygen will be higher than 50-60%. I think that maybe we can start with iFlow nasal cannula, especially with these what I call some basic devices that cannot deliver 100%, like the Fisher and Paykel and like the V60 and so on. And so I think that in the future we'll see iFlow nasal cannula coming in earlier because of those effects that I've mentioned at the beginning. And then I think that after this conventional oxygen therapy part, if the patient is has a PaO2 FiO2 ratio below 300, I think we should ramp up to iFlow. And I think that the way I would recommend was to increase the flow as much as possible. The majority of the machines can allow for 60 liters per minute. Some more recent, especially the invasive ones, can go to more than 60, but I think that 60 is fair enough. And then after you reach the 60 liters per minute of flow, then you can titrate the FiO2 to maintain again the same target. So more than 93, so between 93 and 96. And then is when CPAP can be introduced. I think that we heard a lot of CPAP, and I think CPAP is fantastic, especially for patients that are obese, especially for patients that show on the CT scans a lot of ground glass opacities on the periphery. And I think that it's important that you titrate CPAP max 10 centimeters, maybe 12 maximum, and also FiO2 to maintain these saturations. I think that CPAP is good when iFlow doesn't work, especially when the patient is below PaO2 FiO2 ratio of 200. And I think if you have helmet helmet can be very useful. Helmet can allow the patient to be on CPAP for longer periods without leaks, which is important. But still, you have to be very cautious of how you're delivering CPAP, because I think with the helmet, you cannot use normal home ventilators. So you need very performant turbines, or especially, as some authors recommend, to use Venturi flow systems that are very performant. They can deliver up to 120 liters per minute, which is very important to avoid rebreathing with these very huge helmets. And I think in the end, we see Bilevel in this arrow here, that is like a last resort when high-flow CPAP is not working, especially in the hypoxemic. So if you're having a hypoxemic patient that is not responding either to high flow or to CPAP, you can try Bilevel, also with that concern of the possibility of increasing transpulmonary pressures. In my algorithm, we indicate very low PaO2 FiO2s. Of course, this should be done in highly surveilled spaces, so high monitored spaces with very experienced staff, because we are talking of very severe patients. And as I mentioned before, so the hypercapnic, I think, can be also the ones that can be more effectively treated with Bilevel. And then in the end, at the lower part of the slide, we see you see the self-proning. Self-proning, I think, now is much more used, even at the beginning of the natural history of COVID-19. So you can ask the patient to self-prone even when he's on conventional oxygen. And when he's on high flow, you can also use it. It's more difficult when you have the patient on helmet CPAP, but it's also possible. There are some tricks. You can put some pillow inside the helmet to allow you to rest on your head while you're with your belly down. And I think it's important that you test if proning if your patient is responsive to proning. Again, it depends also on the CT scanning and also on the response. Not every patient responds, but if you respond, so if there is an increase, like let's say 20% of the PaO2 FiO2 ratio, so it's a responder, and so you should extend the time as much as tolerated by the patient. And now we have very interesting devices coming to the market that allow this self-proning more comfortably, because normally there is no ideal pillow to make sure that our patient is quite comfortable. Now we have some devices on the market, some inflatable devices that can fit very well to the patient's anatomy and prolongs much more the time that the patient is on the belly. So I think that self-proning is something that we have learned also from the first wave, and we are seeing more and more people being self-proned.
Fantastic. Me just, sorry, get rid of the laser pointer. There we are. And stop sharing my screen. Perfect. That was a brilliant summary. And
Thank you.
It finishes off everything beautifully and explains what we should be doing. I think what we're going to find is that self-proning will also be happening post-COVID for a variety of reasons, and
absolutely,
it would be a shame to waste all of the innovation that has been coming out.
Yeah.
But thank you so much for talking to me today.
Thank you.
It's been amazing, really. And I've learned so much.
Thank you.